Hey everyone, as promised, this is going to be a quick review of chapter 24 for honestly before or after lecture. I'd prefer you'd all listen to this before lecture, but let's face it, I know it won't always happen. Personality disorders is one of my favorite lectures. However, it's difficult because we have these 10 different disorders that we need to be able to differentiate. And we put them into what are called clusters because we tend to see the same types of traits within the cluster. So cluster A, we see them as eccentric. These are odd individuals. Cluster B, it says erratic. I've also seen dramatic, emotional, and that kind of fits all of those individuals in cluster B. Cluster C are anxious. They are fearful. They're insecure. And we see that a lot. And when we get to each of these disorders, you'll kind of see how it relates to the cluster that we put them in. So epidemiology and comorbidity, about 6% of the global population. In some instances in the United States, it says it could be up to about 10%. So these are pretty pervasive. And we see them in a lot of psychiatric patients in addition to their other diagnoses. It is very common to have a patient in mental health who has more than one diagnosis. And you'll even see with a lot of these, we see them high in substance abuse. When we talk about culture and when we talk about personality, right? Personality disorders represent who we are. Our personality is what makes us us. So we see this breakdown in who our patient is. We see difficulties with relationships, with mood dysregulation, with how our patients interact with other people. Genetically, we do see some higher incidence in some of these personality disorders in family members who have depression, substance use, even schizophrenia, especially some of our cluster A, those odd and eccentric. Some of those patients may have a first-degree relative with schizophrenia. Neurotransmitters, we can see neurohormones may regulate our temperament, but it's not kind of a huge thing. Psychologically, Freud, right? Childhood experiences are what creates these. So in personality disorders, our defense mechanisms, repression, suppression, regression, splitting, have been identified as being what we use dominantly. It's really, Freud isn't supported by learning or by evidence. Learning theory says that we learn these maladaptive behaviors from our role models, from our parents. What does our parents do? When we talk about environment, right, childhood neglect and trauma is seen as huge risk factors in many of the personality disorders. And we always have that diastasis stress model, right? When we talk about psychopathology, correlation between trauma, neglect, dysfunction, along with your genetics and your predisposition. So we're going to go into the different personality disorders. What I want you to remember as I talk about these are long-standing maladaptive patterns of behavior that involve how your patient relates to others. So personality disorders, their biggest influence is in the social and personal relationships that our patients have. They struggle to form adaptive social relationships, and many of these patients will have maladaptive relationships. So cluster A, we're going to talk about paranoid, schizoid, and schizotypal. As I talked about when I told y'all, watch this video before class, I'm going to be giving you some examples of people who may have this personality disorder, but I don't draw from real life. So I'm going to be talking about characters from movies and books and TV. Once or twice might you hear real life, but I'm going to keep it very vague and you'll see why. So cluster A, we're going to talk about paranoid, schizoid, and schizotypal. And again, we need to be able to differentiate between all of these. So we talked earlier this week about paranoid schizophrenia, and this is similar and different. Paranoid personality disorder isn't paranoid in the sense of the CIA is tracking me. They are paranoid in the sense that they have a distrust distrust and suspiciousness of those around them. So they may be hypervigilant in their relationships, jealous. They might always think that their spouse is cheating on them, even though they have absolutely no proof. So because they are so distrustful in these relationships, they may become hostile. They may try to counterattack if they think they are being threatened. We see this more in men than women, and especially this cluster A, these odd and eccentric. These are where we see individuals who have relatives who have schizophrenia. We sometimes see paranoid personality disorder, and then later on it progresses and we may see a diagnosis of schizophrenia, but not always. This could be seen in childhood. Their child doesn't have friends. The child has a lot of social anxiety. They may get teased because of that odd behavior. And again, as adults, poor relationships due to that jealousy, due to the controlling behavior, and they are not going to forgive. Remember, we talked about projection when we did defense mechanisms. If I think my spouse is cheating on me, I'm going to be continuously finding fault and, accusing my spouse of cheating when I am in fact the one who has something within me that is weird. When we're talking about where we kind of see this in life, examples that we've had in the past, Mad Eye Moody from Harry Potter, right? He's got that eye. He does not trust anyone around him. We did go through a Harry Potter marathon in my house as I was preparing for this lecture last quarter. So I have a lot of Harry Potter examples. A student once suggested Medea. I have never seen the movie, but if you have, those are people we might think of who have this disorder, who represent traits of this disorder. Treatment, we have to follow schedules. We have to try not to be too friendly. We want to be neutral, but nice to them. Straightforward explanations of what is happening of the test. Use simple language. With almost all of our personality disorders, we're going to talk about limit setting and letting our patients know these are the boundaries. This is what is appropriate and this is what is not appropriate. Unsurprisingly, these patients are going to reject treatment because they don't think they need it. For all of our personality disorders, we are going to remember psychotherapy is the first line of treatment. Because it is personality, they need therapy. Meds can be helpful. If they have anxiety, we give them anti-anxiety meds. If they have agitation, we may be treating them with antipsychotics. But medications are going to be based more on the symptoms and less of the diagnosis. Individual therapy is going to be the one for paranoid personality. Group therapy, they may feel threatened just being around so many different individuals. Our second personality in cluster A is going to be schizoid. And just to get it out there now, my example of schizoid is going to be from the movie The 40-Year-Old Virgin. So if we think of that main character, I can never remember who plays him. I want to say Adam Sandler, but I know it's wrong. They're individuals who are extreme loners, social withdrawal, maybe restricted range of emotions, flat affects, and they are seen as odd and eccentric due to their discomfort with social interaction. So if you've ever seen the movie The 40-Year-Old Virgin, he's at work and he walks up and they're all playing poker and he's like trying to interact and they're just like, dude, what are you saying? Like, what type of behavior is this? So because of their discomfort and their just weird social reactions, that's how they are viewed as odd. We see this maybe in nearly 5% of the population, again, more with males, again, more with individuals who have families' history of schizophrenia. In adolescence, they may do, again, poor in school. They may be teased a lot because they stay so alone. Relationships are difficult because they have this emotional detachment. They don't seek out or enjoy close relationships. And they don't really care about your approval or disapproval. So friendship, dating, sex is rare. They do have, and this is where I tie in my 40-Year-Old Virgin reference, numerous imaginary friends and fantasies. So in the beginning of the 40-Year-Old Virgin, right, he lives in this house. He has all of these toys and action figures, and he's more comfortable interacting with them than with other people. Now, when we do think about employment and our ADLs, right, employment's the big one. if this individual has a job where they need to interact with others, they might struggle with it because it is so hard for them. So when we consider what we have to do as nurses for these patients, again, we don't want to be too nice or too friendly. They are uncomfortable with those social aspects. Group therapy could be helpful. However, again, this might be the silent individual. We might have to be mindful of how everyone is interacting in the group, if people are making fun of them. Antidepressants may help increase pleasure. And again, antipsychotics could also help with that restricted affect. But they struggle with socialization, so we do not want to force socialization because it's just hard for them. Schizotypal is going to be our last in cluster C. We talked about, when I told you all I'm going to be referencing characters, this is my Luna Lovegood. So for anyone who knows Harry Potter, I would say Luna Lovegood is a good example to fit into this. These are individuals who don't blend in the crowd. They're strikingly strange and unusual. They have this magical thinking, odd beliefs. Their speech, can be a little bit strange. Their affect inappropriate. Again, we see this more in men, more in young individuals, and more in those who have a family history of schizophrenia. And because they are just so odd, they have these social and interpersonal deficits. They can be more anxious in social situations. While they may contribute to conversation, you're like, what are you saying? And they could have some paranoia or be overly suspicious of other people. They may have some hallucinations, but to a lesser degree and only briefly, not as invasive as we would expect to see in schizophrenia. The big difference when we're talking about the hallucinations in schizotypal and schizophrenia is that in schizotypal, you can usually make them aware of what is happening, of the suspiciousness, of the magical thinking. Schizophrenia is a far greater set of delusions and hallucinations. The last line here, invulnerable to involvement with cult or unusual religious or occult groups. These are going to be the people who join, right? Jim Jones and the People's Temple. These are going to be the people who drink the Kool-Aid because they will believe it. If I drink this Kool-Aid and put on the special clothes, a UFO is going to come and take us off to this magical paradise, and they will fall in line and believe it wholeheartedly. So as nurses, what do? Psychotherapy, right? Watch out for safety. Respect the need for social isolation. Because of how different they present, they really do struggle with group therapy. I have had a patient who had schizotypal probably about 2 years ago, and it was an addiction. He had a co-occurring substance use disorder and schizotypal. And in substance use, we really required the patients to go to group therapy. That was why you were here. There was no reason to skip it. But this was the patient we let skip group. Not every group, but there were times where he was like, I just kind of need to be alone. He really struggled with the social reaction in groups. So we need to be mindful. We can't be judgmental. We cannot make fun of these beliefs. Again, psychotherapy, make sure they're not in a cult. And then especially with the hallucinations, if they do have some, a low-dose antipsychotic would be the treatment. But like most, therapy is going to be what is needed. I'm going to skip for the sake of time. It's going to let me skip over this video. And we're going to go on to cluster B. These are erratic, dramatic. These patients are emotional. And some of these are the ones we are going to see most likely, most often in a clinical setting. So if we're talking, who are you going to see in the hospital, especially in a psych unit, borderline, without a doubt. So histrionic personality disorder is our first one. Back when I went to nursing school, we described these as soap opera stars. However, I realized soap operas aren't nearly a thing like they would back, 18, 20 years ago. So now we talk about like any reality TV star, your TikTokers, your influencers. So while I am talking about specific people, I'm leaving it vague. They are exciting. They're excitable, dramatic. They have bold behaviors. They're self-centered. It is all about them. So in a relationship, they don't necessarily care about their partner. They want 100% of the attention, always on them. They could be provocative. They could be excessively flirtatious, smothering. These are extreme extroverts, flamboyant, their clothes, their mannerisms, everything about them. We do, shockingly, we now switch, tend to see this more in females than males. I know, shocking statistic. And when their relationships end, because it was all about them, they did not care about their partner, they have no insight. We see symptoms tend to start in early adulthood. It could go both ways. Again, psychotherapy is our treatment of choice. But most of our patients don't think they need help. They go in for treatment for other symptoms. Medications can be used for their symptoms, but main psychotherapy. What do we have to think of when we're talking about nursing care? Seductive behavior is a response to distress. If you are not interested in them because they need to have that attention, they may come off as more seductive. We have to be professional. We have to ignore flirtations. We have to model appropriate behavior and boundaries. We want to figure out what the inner feelings are. I am doing this because I feel sad, because I feel anxious. And we want them to be able to talk about their feelings versus presenting in this way. Now, because they're so dramatic, this is the patient, and honestly, I know someone who did this. They got like a tiny little 1st-degree burn and lost their mind screaming, "You need to call an ambulance. I have a 10th-degree burn." Exact quote. Even though we know they're being dramatic when it comes to nursing care, we have to investigate those complaints. Okay, you have a burn. Let me see that burn. You don't need to go to the hospital at this time. Let's take these steps and start treating it. But we still always need to investigate those medical symptoms, even if we know they're probably blowing it out of proportion. Narcissists. So this is a hard one when we talk about like who would be a narcissist. Students in the past, one of our references for this would be Dr. House. If anyone remembers that TV show, my Harry Potter reference would be Gilderoy Lockhart. We, though, know there are plenty of other narcissists. Usually a student always suggests their ex. And these are individuals who have this exaggerated sense of self-importance. They think they're entitled to everything. They think their poop does not stink. They have no empathy. They are going to exploit others because I'm the best. This personality disorder is one that is specifically associated with less impairment in functioning. They tend to do okay. But when we look at these patients psychologically, they're super weak on the inside. They're sensitive to criticism. So when we criticize them, they tend to like jump and lash out because they have to maintain that I am the best. We do tend to see this more in males than in females. It's difficult to give an age of onset. If we look at how this develops, we may see parents who give their children an unrealistic sense of talent. My son is the best. I don't know why the coach isn't playing him. We, doing soccer with my kid, have a kid whose parents spend all this money. They send him to all these trainings and then got so upset in the championship game when their son did not play. However, the coach put in the better players because we had to win the championship game. And the parents, honestly, they stopped letting the kid come to soccer because the coach didn't recognize how good you were. If that is told to these kids from a young age, they tend to think I am the best. Arrogant. They may be open to shame and embarrassment, especially abandonment. So if they may feel underappreciated by others because they are the best. What do we have to think about with nursing care? Remain neutral. We don't want a power struggle. We set limits. If they want phone time and phone time's not till 4 p.m., sorry, you can have a phone call at 4 and we leave it there. A lot of individual therapy. These patients are often not going to seek help because they don't believe they're a narcissist and they don't want to be labeled as narcissistic. Cognitive behavioral therapy is great. helps look through that faulty thinking. What are the negative thoughts? How can we change them into positive thoughts? Group therapy is good for this patient because of that role modeling empathy. They can see how others interact, and we can appropriately in a group therapy session kind of call them out. For patients with mood swings, we can do lithium. If depression is seen, we can do antidepressants. But again, meds are going to be based on what we see. It's going to be primarily group therapy. The next one is one of my favorites, antisocial. We talked about this very briefly, and y'all are like, antisocial, they don't want to hang out with friends. Again, not what we're going to be thinking. Antisocial, a great example is Jeffrey Dahmer. These are serial killers, criminal misconduct, substance abuse, right? Prevalence 1.1%. And though we have this little Willy Wonka graphic here, I think it's more the quote, you got hit by a car, I'd feel bad, but I have antisocial personality disorder, because they don't feel bad about things that happened. I would say Willy Wonka is more schizotypal if we are going to put him into a category. But, and I don't do serial killers, we can talk about that later. I want to say this is Dahmer, but it could be someone else. But these are individuals who are deceitful. They're manipulative, and it's all for personal gain. They are hostile if their needs are blocked. They have these disinhibited behaviors, high risk taking, disregard for responsibility, impulsivity. When we talked about conduct disorder previously, if conduct disorder is not treated, they grow up to be patients with antisocial personality disorder. So conduct disorder as kids are antisocial as adults. You see these patients commonly referred to as sociopaths, psychopaths. If we are looking at the definition of psychopaths, the definition does say that those individuals do have antisocial traits. This is an adult diagnosis. We tend to see symptoms peak into the mid-20s. By age 40s, the symptoms tend to kind of even out or maybe subside. They're antagonistic. I think we've already talked about a lot of this. Callousness is a big thing. No remorse, no guilt. They don't care about punishment. They don't care about meeting family, school, other obligations. They may be shallow. They may be very superficial. They may seem like they have feelings and they care and that they're concerned, but that's only if it's going to help them manipulate and exploit others. They may be witty, they may be charming, they may be good at flattery because they want something from you. So what do we have to do? They may not answer honestly. Oftentimes, if they're in healthcare, they might have been court ordered to do so because of their diagnosis. Self-assessment, we need to look at us. How are we interacting with these patients? If we know that they have a history of rape and murder, if we know they have been stealing money from little old ladies, we have to be aware of that. Lots of injury, lots of substance abuse. Nursing diagnosis, risk for other directed violence, defensive coping are going to be a lot of the things that we are going to see in these patients. They're going to be stealing food or clothes from other patients because I want his shirt or I want his food. And we have to set limits. These patients are so manipulative, we don't have a conversation. We just limit set. Oh, you want to make a phone call? Absolutely not. Phone call time is at 4 p.m. And when they're like, well, let's sit down and talk about it, the answer is no. No is a complete sentence. So we have to watch out for things that could injure others. Outcomes, if we're talking about aggression, coping, health promoting behavior, what we're going to see, but they are going to be difficult to accomplish. With these patients especially, the priority is safety. And a lot of times it's the safety of others. We've kind of already talked about these: set boundaries, set limits, realistic choices, use teamwork if we're going to be talking to these patients. No approved medications. We do see some off-label use, mood stabilizers, so your anti-epileptics being happen. They're not advanced practice. They're not really sticking to treatment. They're not seeing providers regularly unless it's court ordered. So borderline personality disorder, if any of you have worked in the healthcare system, this is one you have seen so frequently. The movie Girl Interrupted is a good one that talks a lot about what is borderline. One of the main characters does have that diagnosis. And these patients are seen so often in hospitals because the high risk of suicide. Having traits of personality disorder is a risk factor for suicide. So we are going to be thinking suicide in these patients. Marked instability, no emotional control, no emotional regulation. They're impulsive. They have high risk of self-harm, self-image distortion, unstable mood, unstable interpersonal relationships. I honestly always joke that this is like every teenage girl. They cling to relationships. Their whole identity, self-image is so distorted, and they cling to this relationship. And when something happens and the relationship ends, if you leave me, I will kill myself, is often what we see. That key feature in borderline is that emotional ability, going from one motion to another. This a lot with anxiety, with mood disorders, with substance abuse, which makes this very hard to treat. Hostility and anger, that splitting, inability to view both positive and negative aspects of others as part of a whole. You are good or you are bad. There is no in between. So if we're talking about like at work on a psych unit, Mr. Joe, you are the best nurse ever. Everyone else is so mean to me. I don't know why they're so mean. I don't know why you're so nice, but you are the best. I love you. And they just go on and on and on and on. But then once Joe does something, Joe, can I have an extra phone call? No, phone time's at 4. You're the worst. Do you hate me? And they just go back and forth. So we have to set limits. All of our staff are wonderful. All of our staff are trying to help you, and just very vague. We can't buy into that, night shift, day shift type stuff. If they come in, again, we're going to see these most often in treatment because depression, anxiety, suicide, self-harming behaviors. They are going to have repeat hospitalizations. 1.6%, 10% suicide rate. 10% suicide rate. So we have to focus on safety. They are going to use healthcare services more than others. They're going to have lots of other different disorders. We do see this 5 times more common in those who have a first-degree relative. So if you have a family member with borderline, you are more likely to see it. We do see serotonin come into play. Some child psychologists do talk about separation from the mother. If the child is separated as an infant, as a toddler, and that bond between mother and child, it can help perpetuate it. I've even read some studies where they talk about brain changes, where we see the corpus callosum being different in females who have borderline personality disorder with a history of abuse. So we do tend to see things going on genetically and biologically in these patients. Assessment, structured interview, the multiphasic personality inventory. I like it. Just kind of is one way we can assess a different way to get that diagnosis. It's talks about reliability, how we can interpret. Self-assessment, we have to look at the therapeutic relationship. We have to understand if the patient's getting upset, if they're cursing, if they're yelling at you. It does not necessarily have to do anything with you. Nursing diagnoses, again, safety, mutilations, suicide, violence is going to be the biggest. When they're in crisis, they really do struggle with those social interactions. They cannot form reliable relationships. Outcomes, what are we going to look at? Improving the relationship, cut down on the manipulative behavior. Mindfulness is a big one. When we talk about different types of therapy, we'll talk about DBT, which is a new one. So again, implementations, right? Risk for self-harm is going to be our biggest. We want to make sure we are thoroughly searching this patient, not leaving anything dangerous or harmful in the room. Provide those boundaries, clear communication, right? Set those goals and just be matter of fact, especially those superficial self-injuries. If they are cutting and hurting themselves, we need to just very matter of factly be nice, be therapeutic, but not kind of go into it. Kind of a very big gray area. Pharmacology, again, psychotropics based on symptoms. What are their symptoms? Advanced practice, we want to work on forming that relationships. Dialectical behavioral therapy is kind of our gold standard in what we do, and it does a lot of mindfulness-based therapy that we see is helpful for borderline. CBT can still work if you don't have a therapist who does DBT. Okay, we're going to cluster C. So these are anxious. They are fearful. They are insecure. And we're going to see that throughout all of these when we talk about what they are. Avoidant is hard because you'll tend to confuse it. They are sensitive to rejection. They feel inadequate. They're socially inhibited. They're going to avoid new relationships due to fears of rejection. So this is someone who throughout their life was maybe shy. And we saw that avoidance of relationship increased during adolescence and early adulthood. So this person may have friends. They may have a social relationship. But it's like this is a guy who's had one friend since like childhood. And they have that best friend and they're not making new best friends. This is someone who stays in a bad relationship because it's better to be in the bad relationship than to get in new relationships. They just feel inferior. They're not going to engage in new activities or new people because they're afraid of criticism. They're afraid of the humiliation. We're afraid of rejection. So as nurses, what do we have to think about? We want to be friendly. We want to be reassuring. We want to understand the patient's fears. Group therapy, again, get them interacting with other people. Individual therapy, because group therapy might be hard, is also needed. We want to let them fail. And we want to help them overcome it. So we want them to interact with someone in the cafeteria, say something stupid, and then have a conversation about it, about how it's not the end of the world. Assertiveness training, get them to speak out. Again, no specific medications, but medications can be prescribed based on symptoms. So if someone is having a ton of anxiety, we would give them treatment for anxiety. Dependent personality, this is an easy one because it's what it sounds like. They have a high need to be taken care of. They're submissive. They're clingy. And that creates this fear of separation. It's a personality-wise separation anxiety. They will manipulate others to take care of them. They're going to get upset if their spouse has to go to work. This is very rare. We don't see this truly in much of the population. If we're talking about how this forms, maybe as a child, this individual had a chronic illness. Maybe they had cancer as a child and they had that helicopter parent who was so afraid something was happening. My kid is so sick, they could die, that they were continuously taken care of. And they have this just dependent trait that occurred because of that. They're afraid of separation. They're afraid of abandonment. They don't have confidence in their own abilities, in their own decision-making skills. So it creates problems and they're open and they're more vulnerable to exploitation. Who stays with a narcissist? Those with dependent personality, because that person is taking care of them. That insecurity may interfere with their attempts to become more independent. And when left alone, that anxiety intensifies. Even if it's for a brief period. This person's going to struggle with jobs. We need to encourage them to get a job and be able to make those independent decisions. So guideline for nursing care, look at stressors. Set limits, but don't punish them. Countertransference. So that's when we put those feelings on the patient. If we have someone who really wants to someone to take care of them, we have to set that limit and not take care of them. We need to let them make that decision. Let them go and make their own choices. We want to develop the therapeutic relationship. Again, psychotherapy. There really are no medications for this one. It's going to be based on what they do. This is a hard one when we come up with who, and I realized for avoidant, I forgot to tell y'all who my character was. For dependent personality, one of the ones students suggested in the past is Bella Swan. She's jumping from relationship to relationship. She has to have, for those who don't know Bella Swan off the top of their head, Twilight. I know some of you may not have been teenage girls in the early mid-2000s when it was kind of big. But she's going from relationship to relationship, constantly wanting someone to take care of her. Obsessive compulsive personality disorder. This one gets confusing because you think of the anxiety, the compulsive disorder, OCD. But there is a difference between OCD and OCPD, and we need to know. These are individuals with type A plus personalities. Like they are super stubborn. They have this huge preoccupation with orderliness, perfection, control. We do see this more in men than women. For anyone who remembers the super old TV show movie, The Odd Couple, it's about two roommates, two guys who lived together. I want to say it's from the 60s, and they remade it into a movie, I think in like the mid 80s or 90s. Felix, one of the characters, is a good example where everything's clean and his roommate's a slob and they just cannot get along. They set these super high goals for themselves that may not be anywhere near approachable. And then they get anxious when they can't meet those goals. They will start projects and then end them. They have uncompleted projects everywhere because if it can't be done perfectly, they just don't do it. We see these in individuals who have harsh discipline when they were growing up, those with a first degree relative with this disorder. High rates of suicide in this patient because the anxiety around not being able to be perfect. They may rehearse over and over their social interactions. They may, again, have these goal-seeking behaviors long after it's necessary. That distinction between OCD and OCPD. So this is OCPD. And the big thing is they both have these unreasonable thoughts and actions. However, in OCPD, it's more focused on that unhealthy perfectionism. In OCD, they realize that their rituals are not okay. I should not have to wash my hands 100 times. In OCPD, they push their standards onto other people. So if you have a parent with this disorder, they're going to push these perfection standards onto their spouse, onto their child. These are people you can't go on vacation with because they're going to have a plan. They're going to have a schedule. And if it doesn't go according to plan, they're going to lose it and be so anxious. They struggle with leisure activities and friendships because they are going to be focused on that work, that productivity, and the perfectionist. So what do we have to think about? They may seek help if they're aware of their own suffering, but it may be for anxiety or depression, not necessarily the perfectionist standards. Knowing someone who truly does have this disorder, you cannot tell them that like you should not be washing the walls. They did go get help for anxiety and depression. However, you cannot tell them that, all the other little things that they're doing are not appropriate because they think it is. I'll explain that more in class. Treatment's long, it's complicated. They're just not going to be open to it. Group therapy and individual therapy can again be helpful. Medications, it does list two. Fluoxetine is one, Prozac that I see more frequently for obsessions, anxiety, and depression. But it's going to be based on the symptoms, not necessarily, and the medication will help with the anxiety and the depression, but not with the rigid standards and the perfection. So we'll go again into more detail in class. I was trying to keep this as short as possible. I did it in under 40 minutes. But go through that handout that I'm going to post with this, go through the table and try to definitely figure out how to start to differentiate, and then we'll dive deeper into it in class, or if you're listening to this after class, if you have questions, reach out and let me know. And I will see y'all later.